All right, let's talk about something that can be pretty unsettling for everyone involved. A child who suddenly can't see right. It's a challenging presentation, for sure. But in this explainer, we're going to break it all down and give you a really clear step-by-step approach so you know exactly what to look for and what to do next.
Okay, let's kick things off with a huge clinical pearl. Younger kids, they're not going to walk in and say, "Excuse me, I seem to be experiencing diplopia," right? They're going to show you. You'll see them squinting all the time, maybe covering one eye with their hand or walking around with a new funny-looking head tilt. These behaviors aren't just quirks. They're your first big clue that something is wrong with their vision.
So here's our game plan. We'll start with the most important first step, that initial fork in the road. Then we'll dive deep into the causes of double vision, look at some red flags, and then switch over to blurry vision. And finally, we'll wrap it all up with a solid, systematic way to evaluate these kids. When that child comes into your clinic or the ER with a vision complaint, your very first question is, without a doubt, the most important one you're going to ask. The answer you get will immediately send you down one of two totally different diagnostic pathways. And here it is. This is the simple test that splits the whole work up in two. You just ask the child to cover one eye and then the other. It's that easy. If the double vision goes away when either eye is covered, you've got binocular diplopia. That's a brain or a nerve or a muscle problem, an alignment issue. But if the problem is still there in one eye, even when the good eye is covered, well, that's a monocular problem. It's an issue with the eyeball itself. This is your fundamental branching point.
So let's head down that first path, the binocular diplopia path. When you're thinking about eye alignment, it almost always comes down to the three cranial nerves that control eye movement. If you can get a handle on these, you can decode just about anything you'll see on your exam.
First up is cranial nerve 3, the oculomotor nerve. This thing is the major player, the workhorse. It controls most of the eye's muscles, it lifts the eyelid, and it's in charge of making the pupil constrict. It's a big deal.
So the classic textbook presentation you have to know is an eye that's stuck looking down and out. Now, why is that? Well, think about it. If the third nerve gets knocked out, the fourth and sixth nerves are still working, and they're now unopposed, so they pull the eye down and out. When you see that classic eye position plus a droopy eyelid, that's the hallmark of a third nerve palsy.
You're going to see this on exams for sure, but way more importantly, you'll see this in the clinic. And when you do, a down and out eye should immediately set off alarm bells. This needs an urgent workup because you absolutely have to rule out really dangerous things that can compress that nerve, like an aneurysm or a tumor.
Okay, next up is the fourth nerve, the trochlear nerve. It has a very, very specific job. It only talks to one muscle, the superior oblique, which is the muscle that helps the eye look down and in.
The real giveaway here, the thing you might see from across the room, is that compensatory head tilt. The child will tilt their head away from the side of the bad nerve. And this is just a brilliant little trick their brain is doing to try and realign the images and get rid of that annoying vertical double vision. So, if you see a kid with a new head tilt who's complaining of double vision, especially when looking down, you gotta be thinking fourth nerve.
And finally, we have the sixth nerve, the abducens nerve. Its job is simple but crucial. It controls just one muscle, the lateral rectus, and that's the muscle that moves the eye outward. It abducts it.
This one is a perfect example of what we call incompetent strabismus. It's just a fancy way of saying the eye misalignment is worse in one direction of gaze. In this case, the eye turns inward, and it's at its worst when the kid tries to look toward the affected side. So what do? To compensate, they'll turn their whole face toward the paralyzed side. It's clever, right? It keeps their eyes pointing straight ahead relative to their head, which lets them fuse the two images together. Okay, so we've got the nerves down. But what if it's not a nerve problem? Double vision can also be caused by, mechanical issues, something physically getting in the way inside the orbit. Let's look at two red flags you absolutely cannot afford to miss. So if you get any history of blunt trauma, a kid who got hit with a baseball or took a fist to the eye or fell face first onto a toy, this diagnosis has to jump to the top of your list. The floor of the orbit is super thin, like paper thin, and it can fracture pretty easily. The classic can't miss sign is the inability to look up. When that orbital floor breaks, the muscle that pulls the eye up, the inferior rectus, can actually get trapped in the fracture site. It's physically stuck. So trauma plus double vision, when they look up, that's a blowout fracture until you prove it's not.
Now, this is not the same thing as the much more common periorbital cellulitis. This is an infection behind the eye, in the fat and muscle surrounding the eyeball itself. And this is a true don't let the sun set on this kind of ophthalmic emergency.
The two cardinal signs that should make your alarm bells scream are proptosis, a bulging eye, and pain with eye movement. Why? Well, that infection and inflammation is happening in a really tight space behind the eye, so it pushes the eyeball forward, and it makes any movement of those inflamed muscles incredibly painful. This is an emergency. It needs IV antibiotics right away to prevent permanent vision loss from the optic nerve being compressed.
All right, let's totally switch gears now. We've talked a ton about double vision. What about that other path? What about the kid who doesn't see double, but just says everything's blurry?
Now, the good news is, most of the time this is going to be something benign, run-of-the-mill pink eye, a simple corneal abrasion. But you have to be vigilant for the stuff that can threaten their vision. You have to think about keratitis, especially in a kid who wears contact lenses and has severe pain. And you have to think about a traumatic hyphema after an eye injury. These are the situations that demand your full and immediate attention.
Let's just focus on hyphema for a second because it's so critical to spot. This is not just a broken blood vessel on the white of the eye. This is blood inside the eyeball pooling in that front chamber between the cornea and the iris. And the big immediate danger is that all those little red blood cells can clog up the eye's drainage system. When that happens, the pressure inside the eye can spike, and that can damage the optic nerve really, really fast.
So, we've covered a lot of ground. We've talked about the major causes. How do we actually put this all into practice at the bedside? How do we systematically put all these pieces of the puzzle together?
Look, your history is your superpower here. It's the most powerful tool you've got. Start with the big one. Are you seeing double or is it just blurry? Then, did you get hit in the eye or fall down recently? Ask about the whole body. Any fever or headache? Then zoom in on the eye. Does it hurt? Is it red? Does light bother you? And please, don't forget the big one. Do you wear contact lenses? These 5 questions will get you 90% of the way there.
And of course, the physical exam is where you find the proof. You're not just going through the motions here. You're actively hunting for clues. When you check their eye movements, you're looking for that specific nerve palsy or that muscle entrapment. When you check the pupils, you're searching for that blown pupil of a third nerve palsy. And the fundoscopic exam might show you papilledema, a sign of dangerous pressure in the brain. Every single step adds a crucial piece to the puzzle.
So we'll leave you with this little thought exercise to bring it all home. When a kid walks in with both a new headache and double vision, what are the most serious causes we've talked about that you have to consider? Thinking through that scenario is going to help solidify this entire framework. Keep this approach in your back pocket, and I promise you'll be able to navigate this really challenging presentation with confidence.